Good day, everyone. Welcome to today's ACMQ webinar titled Integrating Learners into Quality Improvement and Patient Safety, Lessons from the C-Suite. Our speaker today is Diane M. Hartman, MD, of the University of Rochester School of Medicine and Dentistry. My name is Angelica Tom, and I am the college's coordinator. Before I turn the presentation over to Dr. Hartman, I would like to spotlight a few housekeeping FYIs. First of all, if you have any issues, technical or otherwise, during the webinar, please feel free to send me an email at atom@acmq.org, or you can also use the webinar chat box, which is in your webinar console towards the right-hand side of your screen. For your reference today, there are handouts that have been provided by Dr. Hartman, and you can also download these at any time. It includes a full presentation slide deck, and this is in the handouts pod of your dashboard. Dr. Hartman was also very kind to provide a reference sheet linking to references pertaining to today's subject. Please note that all participant lines are muted during this presentation, and we will have a Q&A period at the end of the lecture. So if you have any questions for Dr. Hartman, I ask you to kindly use the chat box. Also, feel free to use the chat box when you are prompted perhaps for some questions by Dr. Hartman, just so that she can get a feel of who our audience is today. We're delighted that you all can join us. Now, this webinar is being recorded, and the archive will be made available within a couple of business days on the ACMQ education webpage. However, we will also send this out to you for your reference if you, to look back on, and which will also include a survey. Now, it's my pleasure to first introduce Diane Hartman, MD. Dr. Hartman's full biography is among those handouts in the handout pod of your console. However, I just want to give you some really wonderful highlights about this amazing physician here. She is the Senior Associate Dean for Graduate Medical Education and Designated Institutional Official Professor of Obstetrics and Gynecology at the University of Rochester School of Medicine and Dentistry. She is a summa cum laude graduate of Canisius College in Buffalo and received her Doctor of Medicine degree with academic honors from the University of Rochester. Excuse me. She is the Senior Associate Dean for Graduate Medical Education. In this role, Dr. Hartman is responsible for the university's 80 residency and fellowship programs and over 750 medical trainees. She was appointed to the ACGME Board of Directors in September of 2014. She's a member of the Board of Directors of the American Board of Obstetrics and Gynecology, and she was in this role from 2003 to 2011 and is currently an oral board examiner. She served as the chair of the American College of Obstetrics and Gynecology's Council on Residency Education from 2009 to 2011. She was a member of the Accreditation Council of Graduate Medical Education, so the ACGME Review Committee for Obstetrics and Gynecology from 2006 to 2013, as well as the ACGME's Clinical Learning Environment Review CLER, so Evaluation Committee from in this role from 2012 to 2015. She currently is a member of the American Association of Medical Colleges Group on Resident Affairs and is serving on its steering committee in recognition of her commitment and contributions to graduate medical education. She was awarded the Parker J. Palmer Courage to Lead Award by the ACGME in 2009. She's a fellow of the American College of Obstetrics and Gynecology and a member of the North American Menopause Society. In addition to her administrative and leadership responsibilities, she continues to practice gynecology with a special focus in the areas of menopause and geriatrics. So it is my pleasure at this time to turn the program over to Dr. Hartman. I'm going to switch my screens to give her full control so that we can go forward.
Okay, Angelica, so do I have it now?
You have it now.
Okay. All right, so I've got a box there. Okay, we'll give this a try.
Sounds great.
Thank you for that kind introduction. And I'm happy to talk about a topic that I've been involved in for the past several years, and I'm passionate about. So it's nice for me to have the opportunity to share some thoughts with people that also work in this world of quality and safety. Today, what I've been asked to try to speak with you about is what the current ACGME CLER Program Expectations are for engaging learners in the organizational efforts of the hospitals in quality and safety, and to generate some thoughts, hopefully, about strategies on how this can be done in a helpful way for the trainees as well as for the. As far as my conflicts of interest, I have no financial relationships to this material. I am employed, as was mentioned, as a DIO at the University of Rochester. I am currently on the ACGME Board of Directors, but I'm not in this role speaking for the ACGME Board of Directors. I'm speaking for myself as a point of view of running our residency and fellowship programs for the past 15 years, actually. So I'm taking my ACGME hat, my official hat off, and putting on my my DIO hat here at Rochester. What has happened in graduate medical education over the past a couple of years is there's something called the NEXT accreditation system has come into place, which is now, it's not NEXT, it is the accreditation system. It started about 2 years ago. And as opposed to the system that was in place previous to this, that I won't go into, these are the building blocks of the new system for residency programs, in so much that the institutions and the programs get a on-the-boots, on-the-ground visit every 10 years from the ACGME, but they actually are accredited every year. So there is data and outcomes metrics that have to be submitted every year. And if those outcome metrics, for whatever reason, don't seem to be indicating that the program is strong in various areas of its educational mission, then there may be a site visit that happens to go to the program and to see what might be going on. So really, the whole concept of resident education and accreditation has changed into something that your world is much more comfortable with, and that's continuous quality improvement. So it's looking at our programs chronically and doing oversight and seeing what's working and what's not working and how we can tweak these programs so that we can make them better, which is certainly what's important to all of us. In the context of all of these sort of programmatic accreditation activities, there's this overarching additional program that didn't exist before called CLER, the Clinical Learning Environment Review, and is opposed to where accreditation was really program focused. Are you doing lectures? Are you doing evaluations on the residents? This really takes a step back and says, what kind of environment are those residents living in? When they come to work every day, what do they see happening around them? You know, do the nurses and the docs talk about quality and safety issues? Do they worry about patient transfers? Or is this a place that isn't focused as much on some of those things? And like everything else in medicine, you don't medicine typically by reading it out of a textbook, although many of us certainly have read a lot of textbooks. When you get to the point of residency, it really is following the people in front of you in their daily work and doing what they do. It still really is, in essence, a very apprentice model with some specific educational elements that are certainly there as well. So it's the environment in which they train and in the environment in which you work and you are trying to make significant changes regarding quality and safety that this environmental review program really focuses on. So that just lets me set the stage a little bit. And taking that thought just slightly another step, we used to think of our educational programs mostly being, do you have faculty, do you have curriculum, do you have lectures? And then that was happening, but the clinical care was happening in perhaps a parallel play kind of situation where the care to the patients was being directed by the nurses, the attending staff, the individuals responsible for quality and safety at that institution. And that was working very well, but that intersection between the learner and the patient really wasn't focused on. And where we're going in medicine and medical education at this point is to truly bring those two systems together and get to the point of saying you train a resident well if you have provided good outcomes for the patients that they take care of. And the most important outcomes in your residency training programs is how the patients in your hospitals do, because that really shows the quality of their work, the quality of the interaction that they have with the nursing staff, with the other technical people who are in the environment, because we all know that residents really do have hands-on activities when it comes to patient care. So that's what this program is. It's looking at, as I would say, it's the soup that the resident marinates in every day. And in that soup, what do they learn from everyone around them? And as a result, how does everyone contribute to the quality of the care of the patient? So it's really trying to get at that dynamic. So the CLER program creates this conversation around what we call the clinical learning environment. And the program is a site visit program that's made to look at various environments across the country and then just provide feedback to the community about how things are going. It's important to realize that although the ACGME is thought of as far as an accreditation agency, this is not an accreditation visit. The CLER program is separate from the institutional accreditation that your hospital gets, and it's more of an informational visit to really tell you what is going on in your environment and how potentially can you get better. If you haven't spent a lot of time thinking about these things or understanding what the CLER program is, I've included a couple of articles which were the Sentinel articles when this was launched. An article in JAMA and then another article in the New England Journal of Medicine, and I've given you the reference for those and you can read those if it is something that you want to learn more about and you haven't been intimately involved as much in your own institution. But the CLER program focuses on 6 areas: patient safety, quality, supervision, transitions, fatigue management, which is now going to be renamed physician health and wellness, and the last one being professionalism. And it's those elements that all interplay when it comes to creating the environment the residents live in every day and the quality of that particular environment. So when the visitors come, and I would imagine several of you have experienced a CLER visit because cycle 1 has occurred and now we're in the middle of many hospitals already having their second CLER visit. You know, what they're looking at is basically the integration of your residents into the hospital's everyday operations. How are they embedded in your operations, and how do they learn to work in your hospital and to help you take care of patients in these various oversight areas? So when the first cycle of visits were done, the main questions that were looked at is, you know, who from the hospital is been designed to work with the programs to see that these areas are addressed, and how integrated is the people who lead your GME programs with the people who are carrying out the quality and safety activities and some of these other professionalism activities in your hospital. And then how much interplay there is between the residents and fellows and the people who work in your environment every day. What's happened now as the visits have gone to the second phase is there's been more focus on these other 2 questions because you had a visit and back to look and to see have you done anything with the information that you were provided from that visit. And so how do you determine that you've been successful in perhaps doing this integration that may had been pointed out to you that may or may not have been there. And what areas have you identified after a visit that you want to improve, and how have you handled that information to start to go ahead and make those improvements? Now, I'm not going to spend a lot of time on this. This is something that's called the arc of engagement, and what it does is it just gives you a pictorial view of what happens at the time of a visit. Depending on the size of your institution, yep.
It's Angelica. I do apologize. I got a question from the audience alerting me that this person cannot see your slides. I'm just curious to know if any other attendees are having the same issue. Please enter it in the chat box if you cannot see the slides. Or raise your hand, one or the other. I have another person who's saying that yes, a number, okay. So our audience cannot see your slide deck for some reason, Dr. Hartman. I'm going to
take control of it then?
I'm going to take control of it then. Let me take control of it, and I will bring up the slides. Thank you.
Okay.
This causes a little bit of an issue, audience, in terms of I cannot control the control box and monitor your questions at the same time, but I will take control and we'll at least get the slides in front of you. I do apologize for this.
And then Angelica, I can just say next slide. Is that helpful?
Absolutely. That's exactly what we'll do. So let me get to where we need to be. And which slide were you on, Dr. Hartman, in terms of the?
I was on the one that shows like a half of a circle.
Half circle, okay. And audience, we will,
like around
yes, so kind of like a schematic of flow, that one? Okay.
Yep.
Excellent. All right, I will, just tell me when to move the slides, and I'm happy to do that. Audience, because of this slight issue, I just want to keep the screen as large as possible for you. So if you have any issues from this point on, please email them to me at atom@acmq.org. That is atom@acmq.org, and I'll respond to you from my cell phone, and we will just keep going here. I do apologize for the interruption. Please go ahead, Dr. Hartman.
Okay, Angelica, I'm sorry that this sort of happened. It looks good from my standpoint. Obviously, it's not helpful if no one else can see the slide. So thank you very much for taking over and helping me along the way. So as I was mentioning, this schematic talks about what happens at a visit. There are site visitors that approximately 2 to 3, depending on the size of the institution, that come. The most important part of the visit is that they meet with your CEO and the individuals from your C-suite first thing when they come to an institution. And that's just to get a sense from the CEO and the top-level management perspective of their views on what's happening in those 6 clear focus areas in their institution, and their view of how well the residents have been integrated into this whole process. The site visitors then meet with individuals who are responsible for quality and safety at the institution. That's a separate meeting. They then will have several different meetings with residents and program directors and other faculty. And most importantly, they do these things called walk-arounds. So they get out into the they came to my place. They went to something like 30 or 35 different locations. They see the inpatient, they saw the outpatient, they went to sign-out rounds where the residents were doing resident sign-out to see how transitions in care were happening. They go on the floors, they talk to the nurses, they get a sense for how integrated everything is and what the focus is regarding those 6 areas that we've talked about. And to be very honest with you, by the time they left my place 3 days later and gave me a report, I think I got the sense that they had a pretty good feel for how my place worked. And I'm not sure what you might have experienced if you also had a visit, but it was pretty thorough because they talked to a lot of people. So let's go to the next slide.
Do you see it, Dr. Hartman?
I do not, but I can advance that, I guess. Or I've got a copy.
Yeah, clear evaluation process.
Right. So you all can see it because I can't see it now, but that's okay. I've got a copy of my slides here. Can everyone else see it?
We're good.
You're good. Okay. So in the evaluation process, you get a report right at the end. The team sits down with the C-suite and says, you know, we've been here for the past couple of days. Here's what we saw. And they give a verbal report because they've worked on that the night before. You then get a hard copy of that verbal report that is actually pretty similar to what the verbal was. And then you, all that information de-identified. So once again, the importance of this is that this really is to try to give information back to medicine as a whole on what's going on, not your particular place, like in an accreditation type of situation. So the de-identified information goes into a national aggregate, and then it is placed in a report to come out, and one just did, and I'll talk about that in a minute. Next slide.
Dr. Hartman?
Yeah.
You know, I actually, because I'm monitoring this on my iPhone through the webinar app as well, I actually think the webinar is picking up on your screen, frankly, versus my screen. So could you advance the slides?
Now that and when I'm pushing advance, it's not moving.
It's not.
Now it's not advancing on my slides.
It's stuck on the thematic.
To take over.
Okay.
Yeah.
Because I saw one of your audience, again, I do apologize for this. Okay, then let me, yes, I believe we might be, I believe the webinar is actually on your screen, so it actually worked out well there. Let me try to take back control. Show my screen. Okay. That would have been delightful had we been able.
That would be where I want to be if everybody can see that.
Can you see the clear pathways to excellence?
They're moving on my screen.
Okay, so I've got the control. I do have the control.
Okay. So now you can control,
yeah,
right?
I'm there.
Excellent.
You actually have the control, so
I can?
No, I have it.
No, I can't.
Going from
okay. So when this whole process was put together, there was a collection of individuals who have spent a lot of time in quality and safety in their careers that tried to come up with a description of what an excellent clinical learning environment might look like in the places that the residents live. And utilizing their expertise as well as what's in the published literature about this, as well as what we were seeing from some of the very first site visits, a pathways document was published a couple of years ago, and that's another reference that I put in the reference list. And it's a pretty dense document, but what it does is it breaks down each of the 6 pathways and into sub-pathways, and it gives you a sense for what the site visitors are assessing when they come to your institution. So next slide.
Oops. There we go.
So this just is the first page of one of the sections. So in the patient safety section, there's a pathway. There's probably 6 pathways per each of the focus areas, and then properties underneath that. So if you really want to dig deep into this, this would be the document to find out what the potential things would be that have been identified as being important in the learning environment. Next page. So that pathways document is the framework for now, and it's very fluid, and it's going to be changed every couple of years as we learn more. So look for updates to it, but for right now, it's saying here are the things that you can start to compare institutions across the board, and where we're trying to get information to see how things are going. So next slide. Okay, there we go. Yeah, there should be a couple more lines of information there. Yep, one more. Okay.
Okay.
So Yeah, that's fine. Leave that right there. So the first round of visits is over. There were 300 visits that were done. Were in institutions that had at least 2 residency programs or more, and that accounts for about 300 places. And all that data was just put into something called the National Report of Findings, which was published in 2016. As I mentioned at the beginning of the talk, many of your institutions actually had a second visit, and we're into cycle 2. We're probably about halfway through cycle 2. And in addition, in cycle 2, it's not only the ones with 2 or more that are going to get visit, but even if you're for example, a federally qualified health center just with 1 family medicine program, in cycle 2, you're going to get a CLER visit as well. So the National Report of Findings was an embargoed copy, was released in February, but the copy that's available to everyone was just released about 1 or 2 weeks ago. And the link for that is also in a resource that I provided for you. And it's again, a pretty dense document with a lot of tables in there. Once again, you will not find your institution in there identified as such. You can look at your own CLER report and then look at the information that was found nationally and do a comparison if you would like. But I think what's most important is, what do our nation's teaching hospitals look like when we're trying to think about each of these areas and the environments in which the residents are learning? There's also going to be some individual report briefs that are going to come out for each of the areas, one for quality, one for safety, one for transitions, and those are going to be coming out over the next year. Next slide. So what did we find? What happened when you took people and you put boots on the ground and you went to 300 of our nation's teaching hospitals? What did they see? And so this data was culled from all of those visits to try to come back with some general themes from those visits. And here they are. These are called the 4 overarching themes. And basically they found that there's a lot of variability in the learning environments on how they're addressing safety and quality. And there's a lot of variability in how each of the learning environments have integrated their residents into those activities in their hospital. There's a lot of variability in if the GME programs are really part of the strategic plan and focus. Have hospitals said, these residents are a potential resource for us because they are providing care at the front lines, and have we incorporated them into our strategic planning as a resource? That was somewhat murky throughout the environment. There was variability to which you coordinate educational resources. So they found that hospitals often had quality education programs for their nursing staff in one silo, and then another potential quality education program for their attendings in another silo, and then maybe GME in a third silo. But people were not learning together about topics that they actually might be responsible for delivering together. And then the last thing is what some people have called the faculty desert, meaning that because the majority of faculty members haven't been taught when they were in training, it's not in their wheelhouse, and it's hard for faculty to have residents on their services, and as they're doing rounds and teaching the residents about various medical issues, to be able to comfortably say, well, now let's think about this care transition, or let's think about any professionalism issues that it might have, or any quality issues that might be going on. And so how to do that from a faculty perspective is something that I think certainly needs some focus and some faculty development for the faculty. It's just, the biggest thing is not to make quality and safety just another thing that the residents have to fit into their lecture series. It's to make these discussions an everyday part of healthcare and how to do that right at the patient's bedside because it becomes part of the conversation with the team. And they found that we're not quite there yet. Next slide. So let me briefly go through each of the 6 focus areas because I think this is where the money is as far as the findings and what you might think as far as where you can make some changes within your own environment. In regards to patient safety, because it is an accreditation requirement, most institutions have said, okay, we got to get that patient safety training in. Let them do a computer module. They've looked at it, they've checked it off, and now they're done with their patient safety training. And I think, you know, we would agree that that's a very efficient use of time. Computer modules are fantastic, and they provide a lot of good information. But the residents need more. Like everything in medicine, if you're going to expect them to be able to truly understand how to do a quality improvement cycle, you need to have them really involved in a quality improvement cycle and thinking it through and getting the data and making the changes along the way. So it's this experiential learning that really needs to be done. Many residents don't know the range of reportable events. They know when something looks really bad and that might need to be reported, but the whole concept of close call and near misses is a little bit foggy when the site reviewers were asking about those and the residents weren't really aware of what those might be. When they looked at your event reporting systems and said, you know, give us the percentage of how many reports are entered by residents, I think the percentage was around 1 to 2%. And if the residents did report something, there wasn't a lot of feedback. The circle wasn't closed in the reports that were made. Certainly residents may have reported things via the nurse on the team, so it wasn't just only 1 to 2%. There are other ways of reporting, but it was hard to really capture how engaged the residents were in reporting. And then there was limited participation in interprofessional safety reviews. If there was an M&M going on, it really didn't involve many professions. If there was a root cause analysis going on, it often didn't involve the residents, and so the whole concept of interprofessional learning really wasn't very strong during the course of what they saw at the visits. Next slide. As far as quality is concerned, when the trainees were asked what are the system's priorities, many of them could say hand washing and things like that, but what they really couldn't do is talk through how to do quality improvement in the more formal kind of ways. There was also real variability between the kind of quality projects the resident might be doing and what the clinical environment really wanted them to do. Again, because it's a requirement for accreditation, many residents were told, well, you need to do a quality improvement project, and they felt like it was a requirement, so they would try to start something, sort of check the box, but they didn't follow it through, and then whatever they came up with really wasn't a major priority for the hospital or in the institution, so it often died. And then again, you know, as you know, most of your quality improvement is done in interprofessional teams, and oftentimes the residents were not involved in those interprofessional teams. Next slide. It looked at something called healthcare disparities, and when the leadership was asked, you know, what is your strategy for healthcare disparities, most institutions talked about trying to provide access for people, and when they talked to residents about disparities or cultural competence, there were pockets of goodness here and there, but many residents really hadn't had these kinds of discussions in their program, and there really wasn't any circling back to your community and what kind of people and disparities that might be in your particular community or in your area of medicine, and how your institution was doing on that and what the residents could do to be helpful in it. Next slide. As far as care transitions were concerned, most hospitals are working on preventing readmissions and trying to effectively get people into post-acute care, and that did involve the residents in many cases. Handoffs continue to be an issue no matter what institution you look in, and many institutions just did not have a standardized approach to how the handoffs were conducted, and fewer institutions had any kind of way to evaluate the trainees and say, yes, here's our standard, here's how we hand off a patient, and I'm going to watch you do it and make sure that you're doing it correctly, which is an accreditation standard. Next slide. As far as supervision is concerned, it's interesting because there's was described both under supervision and over supervision. Under supervision was in areas where the faculty would say, oh sure, there's always a faculty member that's present to supervise that procedure or that care because there's a whole billing issue that's involved. But what the residents would often say is that on nights and weekends, in some places, the amount of supervision that was available really wasn't appropriate for the sickness of the patients or the number of the patients, although on paper it looked like the supervision was there. In the issue of over-supervision, unfortunately, we've gotten to a point that, once again, perhaps because of billing issues, the attending often is hovering, and several surgical residents will comment that, you know, that they don't get a chance to be independent very well, and they're often uncomfortable that last day of residency to the first day out in practice. So life is never perfect, but that was something that was commented on as well. Few institutions, if you went up to a nurse, and as you know, this is a JCO standard, and said, how do you know that that resident could put in that central line, that they're credentialed to do it? How can you check? Few of the institutions, the nurses were able to come up with that procedure and to be able to describe that. And then when it comes to residents and supervision, it looked like the leadership for the institutions, if there was some kind of adverse event, and they looked back at that adverse event and said, wow, what happened here? And in looking at the adverse event, they said, wow, geez, the residents shouldn't have been left alone. There wasn't enough supervision. That's how they found out about it. But very few institutions think about supervision proactively and say, gee, have we really looked at how well people are supervised or what our attending accessibility is, and keeping that as one of your quality metrics. Very few places have incorporated that. Next slide. As I mentioned, when this started out, it was named Fatigue Management, Mitigation, and Duty Hours. It's now changed into Resident Health and Wellness, and it would be hard, I think, to be someone in medicine that hasn't picked up on the fact that there's a lot of articles now on the fact that attendings and residents and medical students are stressed, and many of them are burned out. And so there truly is a national focus on this. What the site visitors found was that the institutions have done their due diligence, and in the vast majority of cases, they're monitoring resident work hours, and the residents are meeting their work hour standards. However, they haven't really looked at if they're really fatigued or not. So the connection between you've worked the right number of hours, but when you're there, are you really safe to take care of that patient? That is not being assessed or evaluated. And then certainly, you know, the faculty are tired. I mean, there's been an outcry from faculty to say, well, residents aren't here anymore, and now I'm doing those things. And also, you know, we're now in a situation where the residents keep changing in more of a shift-like kind of experience, and that's causing more handoffs. And there certainly is a perception by faculty that that may not be contributing on the positive sense to safety either. So again, those were the observations in that area. Next slide. So where do we go with all of this? Kevin Weiss, who is the vice president from the ACGME, that's head of the CLER program, did a presentation in late April via the ACGME website for anyone who wanted to listen, as well as via the American Hospital Association group of individuals who tap into that. And they went through some of these results from the CLER visits, and they also talked about a couple of the next thoughts that I'm gonna bring up. And that is, so if you are an organization, if you are in the C-suite, if you are responsible for the quality and safety in your place, what can these results help you with? What meaning can you find in here? Where do you go next? Next slide. So the suggestion was, you know, don't boil the ocean, but look at the results. Pick out one or two of the overarching themes and say, well, you know, this is where we maybe could be better. So you might say, our quality and safety hasn't really engaged the residents. That's one theme. Or you might say, gee, our faculty members are uncomfortable on teaching this skill set. That's a different theme. And focus on that. So whatever overarching themes seem to work for you and where you think your deficiencies may be, you may want to think about that. And then look at those 6 focus areas and the results of those, the visits, and say, yeah, you know, our residents don't know when to report, and they're not real comfortable with a near miss. And I run the database for our quality and safety. I'm just saying, one of you might say this to yourself, and I don't get a sense for what the residents are seeing as far as near misses that they're thinking about. So think strategically. Broadly, how can we make durable changes in our system, not tactically, not another checkbox that you're trying to fulfill? Again, interprofessional teams in all of these topics are critical. You need to get the program directors into the discussion. If you live in the hospital world, you need to get the people that are running the programs into your world and discussions. And you need to start putting together some plans. So some kind of guidelines that you're going to say, over the next 6 months, we're going to try to hit this target. Some kind of accountable actions, and say, let's see if we can get there. And I think that'll give you a little bit more direction on your journey. Next slide. So John Duvall is the president of the board of the ACGME right now. And in the CLER National Report of Findings, this is one of the pieces of information, one of the statements that he made. And if you read that report, this is in there. But, you know, then he's a CEO. He's a CEO of a healthcare system. Imagine the impact of having all of our graduates across all of our disciplines and across all of the health professions. So not just physicians, but nurses and other health professionals, emerge from their training programs as experienced in the tools and methods of quality improvement and the science of patient safety as they are in their clinical specialties. So, you know, are we running programs that these important components of delivering the best care to our patients are just as important as knowing how to treat that low or high glucose value? And I think ideally that's where those of us that have tried to do some work in this area are interested in moving the needle towards. But this is hard work. This is really moving a mountain because it's a lot of culture change. And so I think it has to be addressed a little bit at a time. And you need to get enthusiastic people from your institutions to be passionate about this and try to make some change. So the last slide I've just got there for questions if anyone has any, and I'd be happy to answer any that you might have.
Thank you, Dr. Hartman. Yes, audience, please go ahead and submit your questions. You can do it one or two ways. You can use the chat box or you can use the questions box, and I will monitor those and then put forth your question to Dr. Hartman.
Thanks, Angelica.
Thank you. Let's see. Okay. Okay, I see some hands going out, so let me take a look at what we have here. Not there. Okay. Well, audience, as you are submitting your questions, I do want to just bring up the reference slide that Dr. Hartman was discussing. I'm just going to close this particular PowerPoint. It is downloadable through your handout pod, but here it is for your reference as well as you type in your questions. We have the, okay. Can you see it on your screen, Dr. Hartman, what I just brought up?
So it lists the JAMA article, the New England Journal of Medicine article, and then the CLER Pathways document. That's what I mentioned as sort of the framework that is used to generate the questions and the activities that are utilized when the CLER team comes to your institution to take a look at your institution. And then there's the National CLER Report of Findings that goes through everything that was seen in that first collection of visits and what the general state of the teaching hospitals are in those 6 focus areas. So if you have some time and you're interested in this kind of work, you may find it helpful to click on those links and to page through them.
We do have a couple of questions, and I'd like to start off with the first one. Are you aware of any current training for faculty on QI and PS to improve their ability to teach residents?
I am, and it's something that that I actually, we're going to buy here for the University of Rochester, and I understand that the cost is not that high. There's the Institute for Healthcare Improvement just released a 7-module product that I have looked at, but my Director of Quality and Safety has, and has told me that they thought it was really well done. And in that 7-module product, it talks about how can a faculty teach quality and safety to trainees. And that is available from, I feel like I'm doing a commercial for the IHI, but that's available from the IHI, to my understanding. It just came out this past month. And that may be some place to start.
Excellent. We have a question from Mary Dolensky, and she is curious to know, how are the CLER visits funded?
Through the accreditation fees that the institutions and the programs pay. So if you choose to have an accredited program or an accredited institution, you have to have an accredited institution to have any programs. There's a charge that is paid to the ACGME annually, same charge for everyone, and that funding is utilized to do all of the accreditation work by the ACGME, the residency review committees, as well as the work of CLER. So you're not charged individually for those visits.
Excellent. Let's see. So audience, if you have any final questions, please go ahead and enter them now. Dr. Hartman, I just want to thank you before we do close out for taking the time to be with us today on this particular presentation. It was very, I think everyone probably got a lot out of it. And let's see. Well, it looks like you are just so good at what you do that there are really no other questions because everyone has the answers.
That would be wishful thinking, but thank you.
No, I think that's true. We just got we're getting feedback coming in that you were excellent and it was an excellent presentation. So from our audience. So thank you, audience, for being such an engaged group of attendees today. And we do apologize for the technical glitches. One day it'll go smooth sailing, and I think in my wildest dreams. But thank you, Dr. Hartman, for being.
Yeah, Angelica, thank you as well for jumping in there and making lemons or making lemonade out of lemons. I mean,
well,
certainly
you're right.
the ability to touch people broadly through webinars and transmit information is a great idea, and I'm so happy to see your organization doing that. And as you said, we'll all get better at this. And,
exactly.
But it does give us a chance to get the information out there in a time-efficient way for someone. So I appreciate your help in helping me navigate the glitches.
Oh, no, thank you. Thank you so much. And your presentation was very solid. And audience, thank you again for your time today. We will be sending out the recording as well as the slide deck, all the materials that you had in your handouts. A survey will follow after this particular webinar with the materials, probably within the next business day. And please go ahead and fill out that survey. It's very important to our education committee who provides these complimentary webinars. And Dr. Hartman, thank you once again, and to your administrative Bonnie, who was just excellent today. So thank you very much.
You all have a good rest of your day.